33-year-old male. Okay, so this is a 33-year-old male with chest pain and syncope episodes.
Alrighty, y'all. I'll talk about the chest pain and then ask for some magic for the syncope. And the truth is, anytime that I hear the words chest pain, yeah, the possibility of something sinister going on is present and has to be ruled out. And the thing that we've talked about quite a bit is the 4+2+2 mnemonic. And that is a reminder that there are 3 things in the chest that are pretty bad, that can cause pretty bad disease: heart disease, lung disease, and esophageal disease. And the 4 cardiovascular causes are acute coronary syndrome, aortic dissection, tamponade, and Takotsubo's. 2 A's, 2 T's. AATT. The 2 pulmonary causes are pulmonary embolism and pneumothorax, and the 2 esophageal causes are either rupture or impaction. So no matter what, when somebody says chest pain, you have to think about those 2 things, those 3 structures and those 8 diagnoses. The truth is that of all of them, acute coronary syndrome is much more common than anything else, which is why we often equate chest pain with myocardial infarction. And so the key question here is, what is the probability of acute coronary syndrome? And that's informed by getting an EKG and a troponin, which everybody will get in this scenario. I think one thing that comes up a lot is, what do you do when somebody young presents with chest pain? How does that change the landscape? If you think about who can get esophageal rupture, it's usually people with sinister, with something going on in their belly, which young people are not immune to, who have nausea, vomiting, and rupture their esophagus. Young people have a lot of esophageal disorders that can result in impaction, like achalasia or eosinophilic esophagitis. Young people are very vulnerable to pneumothoraces through a variety of genetic conditions and through pulmonary and through heritable causes of venous thromboembolic disease causing pulmonary embolism. Young people can get connective tissue diseases causing aortic dissection. They can get tamponade from a variety of reasons. And most importantly, can get atherosclerotic coronary disease through the obesity epidemic or through congenital disease. So your differential diagnosis of chest pain in a young person includes everything that you think about in older people, but actually also a wider net. It's a wider net because genetic diseases can show up this way. Rare inflammatory diseases like Kawasaki's can show up this way. So what's the confusing part of chest pain in a younger person? The confusing part is what I just told you, is that not only do you have to think about everything that you usually think about, you have to think about things unique to young people. But here's why it's confusing. Most people will walk out with no clear diagnosis and will be just fine. And we don't really know why they have chest pain. So the range of possibilities is bigger, but the range of benign idiopathic disease is even bigger. So this is a situation where the numerator, bad things, goes up, but the denominator, very benign things, goes up even more, which makes your job really, really hard, because you know that most people who come into the ER who are this old with chest pain are probably going to be fine. And that's because the denominator dilutes this problem, but it shouldn't dilute your concern up front, and your concern up front should be higher, especially when there's syncope going on. And for that, I'll pass the mic to Rez.
Thank you, Robbie John. Excellent start right out the gates. And while Robbie was speaking, I was thinking, if this chief complaint was hemoptysis, or if this chief complaint was hematemesis or hematuria, what would we have said? We would have said, no, blood per aura or blood per GU tract. Here, we don't want to anchor on syncope because we're not sure if it was syncope. Well, we should step back and say transient loss of consciousness. This should activate the 4 S's, which really, if you were to arrange these based on base rate of disease for all comers, it's going to be syncope first, seizure and syncope tied. Then you think about sugar, like episodes of hypoglycemia, especially if the patient's diabetic on insulin therapy. and then strategic strokes that can hit the reticular activating system and cause transient loss of consciousness. So it's very, very rare. Right now, we are under the operating hypothesis of syncope, but I'm open to the mimics of syncope, specifically seizure. When you approach syncope, I think we have two schemas on our website. The first one is like the first schema I deploy. And if I can't find an etiology in this first schema that I'll discuss, then I deploy the second schema, which is much more detailed, and it involves the rare stuff. And you know the second one is a byproduct of Ravi Jihad. The more detailed and the more rare, it has his signature. The first schema, actually, it was by Stephanie Sherman, and it's a really nice way to remember it. The core, C-O-R, causes of syncope. And after I discuss these core C-O-R causes of syncope, I'm gonna actually ask Ravi a question. And the question I would love to know his impression is that when he gets chest pain and syncope, how does he prioritize? And I know it's hard here because we don't have more information, but if you can just speak on that for a minute, because we have two complaints, which one do we serve as our anchor and then filter through the other one, is an interesting thought exercise. And you all should do this as well. C stands for cardiogenic, O stands for orthostatic, R stands for reflex mediated. I am not going to focus on orthostatic or reflex mediated, because if you think about it, those causes of syncope don't usually cause chest pain. Don't get me wrong, you can get palpitations, tunneling with vasovagal syncope, but not chest pain. So I just want to focus on the cardiogenic. And the cardiogenic, you can think about aortic stenosis. This guy is 33. He could have a bicuspid aortic valve, but it's early for aortic stenosis. You can think about cardiomyopathy, specifically hypertrophic cardiomyopathy. This can be a good, presentation for syncope and chest pain. So the exam is going to be critical. Does that murmur increase with Valsalva or not? You can also think about other cardiomyopathies like ARVD, pulmonary hypertension, pulmonary embolus. These are sort of the structural cardiogenic causes of syncope, which I'm focusing on, as opposed to the arrhythmic causes of syncope, which happen suddenly. And in a young patient, I think if this were structural cardiac, HCM and pulmonary embolism rise to the top of the DDX. So let me pass the mic to Ravi, because I would love to hear his thoughts when he gets to problems. Just how does he think about which one to focus? And I know we don't have much of a history, Ravi, but anyways.
I just love that that we were given 1, 2, 3, 4, 5, 6, 7, 8, 9 words, and 9 minutes later, 1 minute per word, we're still going. You could talk about this forever. And I think my simple answer is reflecting in real life about the analogy you used about hemoptysis. And so if somebody comes in with hemoptysis and has sinus tachycardia, which one would I use? I would use the sinus tachycardia as a barometer of how severe the hemoptysis is. And here, I think I would be inclined to use syncope, or transient loss of consciousness, as a barometer of the probability of a sinister cause of chest pain. And so there's almost no scenario in which somebody has chest pain and they syncopize and they turn out to have a benign cause. So that's where I would be at. I also would honestly doubt whether somebody truly has syncope when they have chest pain, because syncope by definition is a monophasic entity. Something bad happens to you, but then you recover. And so when the undercurrent of somebody who syncopizes is something concerning like chest pain, I doubt that the syncope won't evolve to something more sinister, like persistent hypotension or something more ominous. But that's how I think about it. How does that jive with you? Alrighty, Rafa, give us more.
Okay, I'm going to give you everything into the physical exam. So this patient states that 1 week prior to admission, he had a generalized illness with malaise. Short after, he developed a rash on the face and abdomen, and he noticed that the rash was petechial in nature and confined largely to the face and abdomen. This patient also endorses a prior episode of possible hematochezia, although he's unsure if there was blood, as well as left-sided chest pain that just recently started prior to arrival, that is described as someone sitting on him and rated as 8 out of 10. And on the day before presentation to the ED, he had a syncope episode in the shower, prompting him to seek medical help. And on the further review of symptoms, this patient denies night sweats or fever, hearing or visual abnormalities, cough, shortness of breath, palpitations, nausea, abdominal pain, urinary symptoms, myalgia, itching. When it comes to medical history, this patient has hypertension, his own hydrochlorothiazide and lisinopril. He has type 2 diabetes, morbid obesity as well, subclinical hypothyroidism, and he also had a prior Fournier gangrene 10 months before. And that's the end of the other quote.
Wow, fascinating stuff. Maybe I'll just comment a little bit on the additional HPI, and then ask Robbie to comment on that as well, because I think it's so rich, and then the background information. What's so interesting now, and I'll tell you reflexively what my mind did, is now the syncope, which was like the forefront for me, the number one problem, has gone to the background. And the reason it's gone to the background is because of this petechial rash, which there's something very interesting about this petechial rash and the hematochezia. Because right now, for me, the syncope could be anemia plus orthostatic hypotension as most likely, if I'm applying base rate of disease. So what I'm putting in the forefront of the problem my mind is trying to solve now is malaise followed by a non-dependent petechial rash. Of course, we have to look at this exam to make sure that it's consistent with the description in the HPI. Something's really odd about this rash. Usually when we have petechial rash, it's primarily in the dependent regions, like the leg, because of gravity and hydrostatic forces, if there's a small vessel vasculitis. If there's a small vessel vasculitis. Let me step back for a second. When you have petechiae in bleeding, basically a problem that we need to solve is this patient's vulnerability to bleeding. Anytime anyone is bleeding, you want to look at the platelet count, you want to look at the PT, and you want to look at the PTT. When, right away, actually, I would just look at this patient's CBC to see if we're dealing with a thrombocytopenia. Because with thrombocytopenia, you can have all of this manifest, but you can have all of this manifest even if the clotting factors are normal, the platelets are normal, if you have some form of vasculopathy. Here's when I'm applying the sequence of events. So I'm trying to explain, what was this malaise this patient was feeling? Could it be the beginning of a monophasic illness that involves the vessels, the small vessels, but also the medium vessels, being the coronary arteries? If you think about what kind of vasculitides might involve the coronary arteries, these include stuff like Kawasaki, though we're not getting that flavor, and this patient is a little old for that. But all of a sudden, with the chest pain and the heaviness on the chest, I am really concerned for this patient's coronary arteries because of the petechial rash that Rafa described. So what would I do next? I would, of course, look at the physical exam, see if we're dealing with a non-blanching rash. I would look at the platelet count, the PT, the PTT, and then I would be very concerned about the troponin and the EKG, just thinking about viral syndrome, then myocarditis, or an underlying rheumatologic syndrome that's involving small and medium vessels, like a variable rheumatologic syndrome. The background is interesting too with this Fournier's gangrene, but I'll pass the mic to Robbie because it's hard for me to really, I think, prioritize at this stage. These are all just speculative.
Yeah, I know. I love that speculation. I was just listening to an Anos on Call podcast with Uncle Bob, where they were challenging the notion or reflecting on the notion of alcohol causing holiday heart. Holiday heart is a condition where people have atrial fibrillation that is associated with acute severe alcohol use. And the discussant was really sharp. He was basically saying, if I have palpitations, I look around and be like, what did I do differently? And you might accidentally pin it on alcohol. Why? Because alcohol use is so common. So I think the tricky part of this case is a lot of people have viral illnesses happen all the time. And the prevalence of a viral condition is so high that you have to be careful to link it to what is going on now with caution, because you don't want to miss the opportunity to diagnose something that is part of a syndrome, but you also don't want to be distracted by a completely high probability incidental event like a viral infection. I don't really have anything to add, Rest, to your reflections on what this could be. But I think I wasn't expecting this patient to have the amount of comorbidities he has. And so that emphasizes that we have to remain anchored in the base rate. And I would treat this patient no different than I treat a 63-year-old man with chest pain, but then use the fact that he's had this unusual prodrome as a potential clue to something unusual going on. All right, Rafa, back to you.
Okay, going to the physical exam, this patient had a heart rate of 102, respiratory rate of 20, and he's saturating 97% in room air, blood pressure 102/55, and temperature 36.7 Celsius. This patient has a BMI of a 60.6. Generally speaking, this patient is a morbidly obese man, poorly responsive to voice, possibly altered from baseline in dry mucous membranes, icteric conjunctiva. Also on the skin exam, there is a petechial rash noted on his face and abdomen. And HEENT exam, thyroid not palpable, no lymph nodes noted, no JVT, large neck with acanthosis nigricans. Respiratory, cardiovascular, abdominal exams are remarkable. When it comes to the extremities, it's warm and well perfused, no edema, no joint swelling, no erythema. When it comes to the neuro exam, he's awake and alert without gross abnormalities. He was confused, and the history is slightly limited as he's somewhat of a poor historian and his speech was difficult to understand. And that's the end of the physical exam. Do you want some initial labs?
Go for it, my friend.
Okay, the white blood count was 9.7, the hemoglobin 7.4, the hematocrit 21.2%, and the platelets were less than 5,000.
I'm really glad you gave us those labs. Maybe what I can do is I'll talk about the exam and leave. I'll leave the labs for Prof. Rest to dissect. I just wanted to reflect on something that that is commonly said, and it's the discussion about our patients being good or not good historians. We use it all the time. The patient is a good historian or not, and I think that that's actually a good thing to pay attention to. But the question is, how should we say what we're trying to say? Is there a sense of precision and lack of judgment? And I think it's not uncommon that any part of the data collection process that we get is impaired. Sometimes the lab specimen is hemolyzed. Sometimes the X-ray angle is suboptimal. Sometimes the CT scan with contrast is poorly timed or the patient's not thrown. Sometimes the patient's moving an MRI, or sometimes a biopsy specimen is not adequate. So the question we have, I think, in the history is, how do we convey that same sense? That sense that the data that we have does not have the same accuracy or quality. And the problem with that is you're talking about another human being. as opposed to a procedure or a process. And so that you have to be a little bit nuanced about how you do that. And so if you look up the term historian, I'll skip over the details, but the historian is actually the person who is writing the narrative. The real historian isn't the patient. The real historian is us. We are writing the history books in the chart. Right now, this 33-year-old man said none of these words. We are interpreting this and putting the story and writing it in the chart. So we are the historians. So when I learned this, I find it really funny that we are like essentially calling ourselves really bad when we say but I think there's a lot of struggles with imposter syndrome and confidence in medicine. So I don't think anybody should call anybody bad. But what I would encourage you to do is, instead of saying a poor historian, judging yourself or the patient, to say the history is limited because the history is limited because the patient's acutely intoxicated. The history is limited because the patient's encephalopathic. The history is limited because the patient has possibly has poor health literacy. The history is limited because, or the history is limited because I don't know yet, and the patient may have embolic calcium in their brain, and we're going to find out at RLR at number 69, the power of the frame. So that's all I'll say. Is the patient isn't a poor historian, neither are you. There's probably a reason that the history isn't what you want it to be, no different than the labs are hemolyzed. And so add that to your problem list. All right, Prof. Rez, mic's yours.
I love that. I was laughing hard because I was just thinking about the number of times I called myself a poor historian in the notes, and I hope I can go back and change those. This is so interesting. I'm almost ignoring everything but the CBC. Like, honestly, you could just say this patient came in with anemia and severe thrombocytopenia. This is our center of gravity, because the thrombocytopenia explains the petechial rash, the anemia explains the chest pain, and probably when the patient is upright is more vulnerable to orthostatic hypotension and syncope. So we can ignore all of that, and if you were to create a problem representation, just say this patient is presenting with likely acute onset thrombocytopenia and anemia. There's a couple of ways that, and notice that the white blood cell count is normal. Usually when you have more than 2 cell lines down, you start making the way to the bone marrow as a primary site of pathology. Unless the 2 cells down are the hemoglobin and hematocrit. I feel like the white cells are the ones that, I'm just thinking about this on the fly, Robbie, they're probably the ones that really puts you more in that center of that bone marrow as a bone marrow pathology. So how can we create a schema for this? Really, there's 3 possibilities here. One possibility is that this patient has just isolated thrombocytopenia, has been bleeding, and then developed anemia. If this is isolated thrombocytopenia, given the degree of thrombocytopenia, one diagnosis is prioritized, and that's ITP, immune thrombocytopenia, or idiopathic thrombocytopenia. But we can't make that distinction just yet. And so we have to entertain the other 2 possibilities. The other possibility is that this patient has an immune-mediated process that's causing ITP and an immune-mediated process that's causing autoimmune hemolytic anemia. This is known as Evans syndrome, most commonly associated with lupus, but anything that revs up the immune system like lymphoma. I think the third possibility, which is the most likely possibility, and Robbie, I'll speak a little bit, but I also want your thoughts on this as well. The third possibility that's the most likely, or possible, I don't know if it's the most likely, it's either thrombocytopenia, bleeding, and anemia, or you're dealing with a microangiopathic hemolytic anemia. So this patient needs a peripheral smear. We need to look at the AST, the bilirubin, the LDH, and the haptoglobin. If we dive in that world of microangiopathic hemolytic anemia, then we can discuss if we're dealing with a condition like TTP or a mimicker like cobalamin deficiency. But I don't want to invest too much time right here until Rafa actually gives us more data, because it'll be interesting. Because if we see that AST is up, if we see that there's schistocytes on the peripheral blood smear, then we can deploy our schema for MAHA. But if the smear is normal, then Robbie will tell you if it's not in its name. More on that in a little bit. Then we can entertain other problems. But before we move on, Rafa, let me give the mic back to Robbie.
I have nothing to add. You're even speaking for me. So I completely agree with you. I think the no miss here is a MAHA, but the possibilities are endless. I love it. All right, Rafa, give us more.
Okay, so
Can I just say one thing? Before this started, I told Robbie I have a headache, and I was hoping that he would speak more than me today. I want to say this is the first time ever in Robbie's life where he's just saying nothing. And I don't know why. I don't know if it's because I asked him that I wanted to speak less, but literally look at our prior episodes. He never doesn't say anything. This is surprising.
Keeping you on your toes, Prof. Rez. Unpredictable.
okay, so the peripheral smear demonstrated 4 or 5 schistocytes, but also 1, 2 spherocytes, non-nucleated RBC with significantly diminished platelets. Okay, so the sodium, I don't know why they give the peripheral smear before the CMP, but okay, so the sodium was 137. The potassium 4.4. The chloride 9.9, 99. BUN 22, creatinine 1.19, the AST 77, the ALT 29, ALP 98, GGT 114, albumin 4.2, total bilirubin 4.1, and direct bilirubin 0.5. There's also urinalysis that showed negative for glucose, trace for blood, negative for protein. The PT was 13.4, which is a little bit elevated, and the PTT was 33.9, which is normal. And the reticulocyte count was 235. With a reference, let me see if it's above or below the reference range. Oh, it's above the reference range. Okay, that's the end of the aliquot.
In the right context, 1 schistocyte, maybe 1 too many. One of the most famous quotations in the New England Journal paper where I first heard about it when Gurpreet Dhaliwal discussed a case of TTP, but I think it quotes a very famous hematologist, a late hematologist, Dr. Bell. And in this context, given the pretest probability of microangiopathic hemolytic anemia, the schistocytes are very, very concerning. And so I think you can proceed with a great degree of confidence that this patient has a microangiopathic hemolytic process. And so the question is, how do we approach that? And I think the thing, like all things, you have to be anchored in the base rate. And the base rate would tell you that the most common microangiopathic hemolytic anemia is DIC, a diffuse intravascular coagulation. And that, thankfully, is actually characterized by 2 things, the absence of which should negate the base rate. And coagulopathy and a trigger for DIC are nearly universal. So you have to have a coagulopathy, and the triggers range from infections to malignancies to obstetrical issues to hyperthermia and to some other rare things. And here we can quickly bypass the possibility of DIC and say the next most common thing is actually TTP. But before we get there, there's some things that we should think about that are immediately actionable that we already should know about the patient. Are they on medications that induce a microangiopathic hemolytic anemia like tacrolimus or cyclosporin? Do they have any reason for us to suspect valvular disease based on their background or on their exam? Do they have any history of transplant, because transplant-related microangiopathic hemolytic anemia is a common phenomenon? And do we have any reason to worry about malignancy? Because all these things actually are things that you should know before you get the labs. A history of transplant, what medications they're on, what their exam is like, or the history is like, or if they have background history of cancer or they're pregnant. These things don't negate the possibility of TTP, but they require you to directly address them, such as delivering the baby, chemotherapy, specific transplant considerations, getting better imaging of the valves, stopping the medication, so on and so forth. And once you've done that, you're still not at a clear answer, there's really 4 possibilities. And that is TTP, HUS, atypical HUS, and scleroderma and APLS. The helpful clue that none of these are play are the absence of any reason to suspect there's citotoxin, but more importantly, the center of gravity of devastation of these things is the kidney, and this is the brain. And here there's overwhelming evidence of brain problems. The Plasmid Score is a score for you to quantify these, this in a more rigorous way, which I encourage you to check out. So I think, you really have to worry about this TTP here. And so I'll pass the mic to Reza to see what else he would add or reflect on that, and also what he might be doing in real time.
Dude, I love that sort of very simple yet rich approach to MAHA. We should hopefully get that on the website soon. I think at this point, this is TTP until proven otherwise. And I think Kushal said it the best, that this patient is in a plex deficient state. And what I did was I actually went to calculate the Plasmid Score. And this patient's Plasmid Score, I'm not sure we have an MCV. Rafa, did they include an MCV in that human DX case? It's okay. I don't think they did. So
no, they did 84.5.
Oh, so they get a point. Okay, so let me show you guys what I'm doing here. Because I think this is pretty cool. Like, I've never really calculated the Plasmid Score. Continue. Okay, so you guys can see my screen right now. Beautiful. So the platelet count less than 30, hemolysis, yes. Active cancer, no. History of solid, no. As far as we know. MCV less than 90, yes. INR less than 1.5, yes. And creatinine less than 2. Plasma score of 7, 72% risk of severe Adams TS13 deficiency. So this is when you're calling your hematologist to initiate plex. And we have this beautiful, you guys can see this illness script for TTP. This is sort of where we're heading next, but this is like one of those things where you can't wait for the Adams TS13 to come back because you may have waited too long. And I think Rebecca really prioritized this diagnosis based on the neuro symptoms. And then once she got the MAHA. So at this point, we're going to probably activate this illness script. And in this illness script, you see we're going to send the, it's a working diagnosis. We start the treatment. And if they respond to treatment, then it's supportive of our hypothesis. And the Adams TS13 activity, not level, activity is going to be less than 10%. Then you come into the causes here to determine, is it an acquired autoimmune? Is it acquired or is it, is it an acquired autoimmune process or not? And we can go through these triggers. So sending an HIV, sending an ANA, and depending on what the antibody test results are, we might be in this category right here. So maybe Rafa, you can give us more data.
Okay, so a chest X-ray showed hypoinflated lungs with no further abnormalities, and a head and abdominal CT, no acute intracranial or abdominal abnormalities. And I'm gonna give you additional labs, which is the last aliquot before revealing the diagnosis. The hepatitis B S antibody was positive, Hep B S antigen negative, Hep B C antibody positive, Hep C non-reactive, and Hep A was not tested. This patient is HIV negative. The DET IgG was positive, ANA negative, LDH was elevated, 1,331, haptoglobulin less than 5. Fibrinogen on admission was 251, which is normal. And there's just one more aliquot, that's the final diagnosis.
Robbie, I have nothing else to add. Anything on your part?
No, I think just to emphasize, like, the reason you're looking for all these things, ANA, HIV, is to look for secondary associated diseases with TTP. And I saw you see the ANA is negative and the HIV is negative. I think it seems that the Coombs test is positive, so DAT. Is that right, Rafa, or did I have that wrong?
It's DAT IgG. I don't know which test is that. Do you guys know?
IgG is positive. So that's the direct antiglobulin test, which is basically the Coombs test. And I think this is a great thing for you to be careful about. So the Coombs test is a test to look for autoantibodies on the red blood cell that cause autoimmune hemolytic anemia. And so what does that mean in this space? And I will tell you that that test is great for autoimmune hemolytic anemia. It's positive in 95% of patients. But that's not the question we're asking here. The question is, what is the possibility of a false positive? And that ranges. In the population at large, about 5% of patients just have circulating Coombs that have no significance. But that a number goes up to 10 or 15% when the patient's admitted and the critically ill. So this Coombs test, in the context of what we have here, it's concerning that it's a false positive because one, it's more likely to be a false positive in ill patients, and two, the case is much more consistent with a microangiopathic hemolytic anemia than an autoimmune hemolytic anemia. But it's easy to see how immune dysregulation can result in an antibody towards Adams TS13 and an antibody towards the red blood cell. The good news is it doesn't matter. Both are treated the same way with suppressing the immune system. All right, Rafa, I'll give you the mic for the final output for Rez to take us home.
Okay, so they did the Adam S13 activity and it was less than 1%, and Adam ST13 antibody 25, which is high. So the correct answer was thrombotic, thrombocytopenic and purpura. And I was reading the discussion, they never addressed the chest pain that this patient had. So on the comments, they were saying that probably this patient had a demand ischemia type picture that led to the chest pain in the setting of TTP.
Beautiful, Rafa. That's the end of the case, correct? Fantastic. Thank you for presenting the case. And I think you do your best to find a secondary cause. And with the antibody being positive, thinking about stuff like lupus that can be associated with it, but the ANA being negative makes that unlikely, if not impossible. So I think that we just leave it at here and see how the patient does with Plex. I really have nothing else to add. Robbie, anything on your part?
Nada, yo. I think it's just amazing how a CBC uncovers the cause of confusion and encephalopathy, and it is a very devastating diagnosis. And I think the thing to realize about TTP is it's a chronic disease. So this patient now will have to be monitored very closely. This is not a monophasic disorder, and their Adams TS13 activity is monitored and their CBC is monitored, and they have to live with this for the rest of their life. We often talk about it as a acute life-threatening diagnosis, but it's actually one that patients have to deal with forever. So it's a pretty shitty thing to have. Sorry for my lack of professionalism here. A pretty poor thing to have, but none of us are poor historians after today, I hope. All righty. Maria, you've been scribing away. Take us home, please.
This was amazing. I remember the first case I discussed was, I think it was a MOHA. I don't remember if it was TTP, but like every time I see one of these cases, I like to know how much more I've learned through them. Like that's how time passes, and I learn more and more, because my first discussion, like I couldn't even recognize hemolysis. So it's always a process. We started with 2 cc's, and when you have 2 cc's, I love this, like where to start. And I love that you can use one symptom to act as a barometer for severity of the other symptom. And I really like that because, diagnosing something is always great, but diagnosing something that is emergent and severe and life-threatening, that is the most important thing you have to do first. So for example, loss of consciousness increases the probability of emergent causes of chest pain, or tachycardia increases the severity of hemolysis. So I like how Robbie uses those 2 symptoms. We started with chest pain, and we always think of emergent causes first. You can do the 4+2+2 schema, thinking about cardiac causes, pulmonary causes, and esophageal causes. Really important that like the most common cause of like emergent chest pain is going to be ACS. And we tend to not think about that in young patients, but in young patients, you really cannot rule out any emergent causes. Like all of the 4+2+2 possibilities can also happen in a young patient. But the thing is that young patients might be trickier, but because you have to include a wider range of possibilities. most young patients will have like non-emergent causes of chest pain and will leave the ER without like a severe diagnosis, but you can't do that. You have to exclude everything first so that the patient doesn't go home with a life-threatening disease. Then we had chest pain plus syncope. And as I said before, syncope can just mean how severe is that chest pain, but always think about the 4 S's of the mimickers of syncope. Don't always anchor yourself in words. So reshape to transient loss of consciousness, and that's going to widen your view of what's happening. And so think about syncope, seizures, sugar, and a strategic stroke. If you do confirm as a syncope, you can think about 3 causes, which are most common: cardiogenic, orthostatic, or reflex mediated. And very importantly, only cardiogenic causes will cause chest pain. So that can narrow down your diagnosis a little bit. Really important is that when we saw the petechial rash, that's where we anchor. So always anchor in symptoms that are unexpected. So for example, we're not used to seeing, or we don't expect, chest pain plus petechial rash, or chest pain plus thrombocytopenia. That changes your illness script, and that changes like program representation, and you're no longer thinking about like your common causes of chest pain, because it's not what you're used to seeing. So really, when you see something that you think, this is different, really pay attention to it. And then when we saw thrombocytopenia and anemia, we really were thinking of ITP, Evans syndrome, or MAHA. And you have to reflexively look at hemolysis labs and smear. I love the quote that one schistocyte is one too many, because this is a life-threatening disease. So when you see something that raises the level of concern, don't dismiss it. So one schistocyte is one too many. Really think about that and don't ever forget it. And so when we see a MAHA, we tend to, like most common causes DIC, this is going to have cardiomyopathy. So your PT and your PTT are going to be elevated. And if not, really think about the second most common cause, which is TTP. And so for MAHA, in the history, you can look for drugs, valvular disease, transplant, history of malignancy, pregnancies, and you have to think about that first. And if the patient doesn't have any risk factors, you can start thinking about TTP. Very importantly, you can calculate the Plasmid Score. I love scores because as a student, you don't really trust your judgment, and scores tell you, hey, you're actually thinking about something that can happen. So I love the Plasmid Score to evaluate for the possibility. And when you confirm it through the treatment and more diagnosis tests, always look for common associations, so infections, autoimmune, or malignancies. Because you can further diagnose the patient with something that is going to cost his life. So yeah, those were the teaching points, and I love the case. Thank you so much.
Amazing, getting better and better every single day. I'm really glad you stayed in medicine, yo. Alrighty. Have a wonderful day. We're actually going to take a little bit of a break from Global Virtual Morning Report tomorrow, but hope to see you all on Sunday or Monday or really every other day. Bye.